Dr. King, if you could tell us a bit about what you see as the implications of PRAMI, what are some of the limitations of the study?
Well, first of all, I think the implication is that in these kind of patients, it was okay to go ahead and stent multiple arteries. In fact, it turned out fine. My concerns that I think we need more information about have to do with the fact that it's a small trial. It is, the mortality is not different. It's 10 and 4. These are two small numbers to hang your hat on. But the primary outcome, which is death and MI and unstable angina, yes, was clearly in favor of doing multiple vessels. But my concern is that in an unblinded situation like this, where, by the way, many more asymptomatic patients had perfusion scans and follow-up in the group who did not have all the arteries opened. And you might expect that. If you have a patient who's opened one artery, you tell the patient, the physician, everybody says, well, he's got a tight stenosis elsewhere. There may be more vigilance in following that patient, and so you do more perfusion scan. And my concern is, does that knowledge of the circumstance cause the patient and the physician to be a little more concerned? Does that in any way drive anything about the endpoints? Does it make people express refractory angina more than if they knew that everything was fixed in the first place? I don't know, but this is one small concern. I think the other concern is, what kind of patients were in this trial? A lot of these were not anterior infarctions. So if the patient had a right coronary occlusion, you open that, and they had a severe proximal anterior descending occlusion, many physicians might even currently, want to take care of that. It may not be inappropriate. But if the interpretation of this trial is that all infarcts now should have all the vessels open, I think that's not what this trial says. And so my concern is that people might be tending to say, the guidelines say just do the culprit artery in the absence of shock and hemodynamic instability. But now with this trial, we can go ahead and stent everything. I don't think that's correct. I think this is something we need to be careful about.
Right. So you don't really see this in the near future having any impact on what the recommended approach would be for these kinds of patients?
I think it may have an impact. I just don't know if the impact will be appropriate. I mean, it may be that people say, okay, now I'm fine, I can go ahead and stent everything, but I don't think that's the right answer.
Right.
Maybe in individual cases, stenting the other vessels is appropriate, but I still think this remains a very clinical judgment. I don't think this gives license to run out and stent every lesion in an acute infarction.